At this meeting, we are presenting a poster where we continue with some of the work we're doing with real-world evidence and models regarding sequencing. Now, we were very interested in understanding how could you predict what the survival might be for a patient who goes with CAR T in second line and then uses a standard of care in third line versus using a standard of care for second line and then using a CAR T in third line. The question is very relevant because people are seeing similar responses and duration of responses with the CAR Ts, independent on where you use them, although, you know, the CAR T 4 clinical trial shows better responses when the CAR T cells are used earlier. So how we did this, we went to the available database. In this case, we went to Flatiron, and then we estimated for the second line, that could be either with a CAR T, with the data for cilta-cel, or the standard of care with the Flatiron, with estimated time to next treatment. Then we introduced, and we did a sensitivity analysis, various rates of attrition. This is a very important point. People don't always have the opportunity to receive a subsequent line of therapy for a number of reasons. One of them is progression and death. So there's an attrition component that needs to exist between the lines of therapy. And then we estimated overall survival from the time that you start that third line of therapy. So that is the treatment of second relapse, and that could be overall survival with either cilta-cel or with a standard of care. So again, it's time to next treatment, attrition, and overall survival for the treatment of that second relapse. In doing so, you can estimate the overall survival from when that first relapse occurs until the time you complete the second treatment. And the results we show are 8.8 years if you first do the CAR T and then do the standard of care, and 5.5 years if you first do standard of care versus you doing the CAR T. Now, people might raise their hand and say the only way to address this in a definitive way would be to do a randomized phase 3 clinical trial, which, you know, would take us 10 years. Until then, we have the approval, and the clinicians have the discretion of deciding when to introduce the treatment. In my mind, I'm more and more convinced the best outcome for patients will be with the early use of the CAR T. Now, there are some toxicities, there are some long-term complications, we have to consider them, but studies like this show the importance of that attrition between lines of therapy. Because if we just look at the study in isolation and someone tells me, well, it has a 5% mortality, that's important, we need to consider it. But if the attrition between second and third line is 15%, the balance is tipped in favor, of course, of the earlier use of the product. So those are the things we have to consider. I think, like everyone else, we wish we had the prospective randomized phase 3 data that would allow you to conclude that this is indeed, how we can do things, but these are options on how we can use it. So for me, it's an important contribution and supports the use of an earlier CAR T.